Welcome to the Asian Pediatric Pulmonology Society 11th Grand Round. Thank you for joining us. I'd like to thank Dr. Wayuni Indiwati, the president of the Pediatric Respirology Working Group of the Indonesian Pediatric Society, for her kind support to co-host this event. Also, a warm thank you to Dr. Rina Triasi, currently works as pediatric respirology consultant at Dr. Sajito Hospital. She is a chair of pediatric training program, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Yogyakarta, Indonesia. We honor that she will serve as the next APPS president next year. And special thanks must come to Dr. Daniel Ng and Dr. Ann Go, the producers behind the scene of every grand round since the first one. And to all the presenters and panelists who generously volunteer their time and effort to create this grand round. So please begin our session, and thank you again for joining us. So please welcome Dr. Rina Triasi.
Okay. Thank you, Prof. Pritipen, and very good evening, everyone. It's my big honor to be a moderator for the 11th Grand Round of Asia Pediatric Pulmonology Society, and I also would like to welcome you all to this session. In this session, we are going to have an interesting case of 10 years old boy with a refractory Chylothorax. And we are grateful to Dr. Madeline Yassin, a pediatric respirology consultant from Cipto Mangunkusumo Hospital, Jakarta, Indonesia, for bringing this important case forward to the discussion tonight. And to guide us through the insight and clinical considerations, we are honored to have an exceptional panel of experts with us. The first, we will have Professor Kunling Sen from China National Research Center for Respiratory Diseases, also from the Department of Respiratory Medicine, the Beijing Children's Hospital in China. We also have Professor Susil Kabra, the Senior Consultant of Pediatric Pulmonology, All India Institute of Medical Sciences in New Delhi, India. And we also have Professor Ngof, the Senior Consultant of the Pediatric Allergy Service and Respiratory Medicine, the Department of Pediatrics, KK Women's and Children's Hospital in Singapore. Last but not least, we have a special guest, our colleague from the Department of Radiology at Cipto Mangunkusumo Hospital, Jakarta, Dr. Muhammad Yanuar Amal, a pediatric radiology consultant in Jakarta. And without further delay, I think I would like to invite Dr. Madeline to present the case. I hand over for you, Dr. Madeline, please.
Thank you, Dr. Rina. I hope that I sound clearly. Okay, so thank you very much for giving me the opportunity to present a case in refractory chylothorax and how to navigate the complexity around it. I'm honored to presenting the pediatric respirology team at Cipto Mangunkusumo Hospital, Jakarta, and Respirology Task Force Indonesian Pediatric Society. So at our hospital, a 10-year-old boy was referred to us due to refractory chylothorax. 7 months prior to admission, he experienced a painless marble-sized lump on left back, skin-colored, no tenderness, soft, and no pain. He denied any trauma, no fever, and it was left untreated. 6 months after that, he said that the lump was enlarged from the marble size to egg size. He experienced shortness of breath, no fever, and no prolonged cough. At that time, he experienced loss of weight. He came to a hospital where he underwent a chest x-ray showing left pleural effusion. At that hospital, left drain was inserted and it showed milky white fluid. With that, he experienced improving shortness of breath as shown in the x-ray. The x-ray is also improved. But after 2 weeks, there was still persistent drainage from the left brain. He had another episode of increased work of breathing, no fever, and no cough were reported. At that hospital, X-ray was performed, showing right pleural effusion. Right drain was inserted, and milky white fluid was drained. He was referred to thoracic surgeon at our hospital. At our hospital, he lost 11.5 kg of weight. He experienced no cough, no fever, no shortness of breath, no known contact with TB patient. And we repeat the history taking. He said that 4 months prior to initial symptoms, he fell but less than 1 meter of height due to fighting with friends. He was previously healthy with complete vaccination. From physical examination, we saw a severely underweight, normal stature, moderate malnutrition boy with a good consciousness, no dysmorphic feature, no paleness, no palpable lymph nodes, symmetric thorax, with a drain in bilateral chest with milky white fluid and positive for indolation. Normal cardiac, but decreased vesicular breath sounds in bilateral lungs with coarse crackles and no wheezing. Normal abdomen, normal extremities, and no clubbing finger.
Okay, thank you, Madeline. And now I would like to invite all of the audience for this polling. With the information that already been presented by Dr. Madeline, what do you think the possible causes of chylothorax in this patient? It is tuberculosis, lymphoma, traumatic, or congenital? Okay, you can choose using the poll that is in the Zoom. Okay, can physicists, can you show the result of the poll? Yes. So between lymphoma and traumatic, it's around 30 to 36%, and the other thinking about tuberculosis, and the last possible causes was thought when the audience is congenital causes. Now I would like to invite Professor Shen to share with us how is actually the approach for the diagnosis of chylothorax in children. Please, Professor Shen.
Okay, thank you so much for the invitation. Can I just have the control? Yeah, I will introduce briefly the approach to the chylothorax and also the possible causes of chylothorax. As all of us know that the lymphatic system and the thoracic duct, actually the lymphatic system transport the lipid and the lipid solid, that mean the lymphocyte and the interstitial fluid and the proteins back to circulation. And thoracic duct transport the chyle from the gastrointestinal system to the systemic circulation while the lymphatic drainage.
Okay, so maybe this is the summary about how the possible causes of the chylothorax in children, whether it is traumatic origin or non-traumatic. So in the non-traumatic origin, we should consider about the possibility of malignancy, syndromal diseases, infection, or miscellaneous. And next, maybe Dr. Madeline, you can share to us what investigations that you already done in the first and the result of the investigation. So we can see what is the what's possible causes in these children, in this child.
Sure, doctor. Physicist, can I get my control? Okay, thank you, physicist. Dr. Rina, I think Prof. Shen is already with us. Prof. Shen, are you there? Okay. Let me move on first.
Oh, yeah. Professor Shen, are you with us?
Is it okay if I move on first, Dr. Rina? Or
Okay, Professor Shen. Okay, so I think she's still freezing.
I think I can move on first, Dr. Rina.
Okay,
So in
no problem.
our hospital, we performed the pleural fluid analysis showing white cloudy fluid with positive revolta test and positive student-free, high cell count, and high cholesterol triglyceride in the pleural fluid. All of the analysis shows that it is suggestive of chylous effusion. After that, we initiate the child with a total parenteral nutrition or TPN because the volume of the chylothorax was more than 20 ml per kg per day. We continue the TPN, and after the volume was down to less than 20 ml per kg per day, we initiate the Chylothorax diet, the low-fat diet. It was okay for a while until the volume started to go up again to more than 20 ml per kg per day. And that time, we initiate TPN again. However, the challenges that we were facing only with the TPN was not sustainable for the child because he developed depression and difficult to maintain only TPN without oral diet. Thus, we tried to combine the TPN with the Chylo diet. However, because it was still more than 20 ml per kg per day production of chylothorax, we initiate the octreotide with initial dose of 2 micro per kg per hour and up titrate. Over the course of the disease, we see that by adding the octreotide, the patient did not show any significant improvement. Thus, the octreotide was tapered down and stopped, and the management for the chylothorax was TPN and a chylo diet. We tried to diagnose what is the etiology of the chylothorax in this patient with three most common causes of chylothorax. The first is tuberculosis, other infection, and malignancy. For tuberculosis, he had negative tuberculin skin test, negative for TB contact, and expert was negative. Thus, he was not diagnosed with TB. For other infection, the patient had leukocytosis and neutrophilia, also thrombocytosis, probably can due to infection. However, the culture was negative. For malignancy, the LDH level was normal, with result from anatomical pathology negative for malignancy cells. So malignancy was not diagnosed in this patient. Other lab result that he had were negative for HIV, and he had vitamin D deficiency.
Okay. So with these recent findings and also the the response to the treatment that has been given by our colleagues, what will you propose for the next investigations? Will you do the CT scan thorax with lymphangiography, MRI test with lymphangiography, or lymphangiogram, or lymphoscintigraphy? Okay. So we see here that most of the audience will propose to do the MRI test with lymphangography or the CT scan thorax with lymphangography. Thank you. And now I would like to invite Professor Cabra about what is the investigations actually we have to perform when we have a child with suspected as having a chylothorax. Prof. Cabra, please.
Thank you, Dr. Reena, and uh, good evening, friends. I'll take you through what are the investigations which you will need to perform in a suspected chylothorax. So, chylothorax is a manifestation of multiple underlying causes, as we have learned in the last few slides, and investigations can be divided into two groups for confirmation whether it is a chylothorax or it is some other kind of pleural effusion or identification of the underlying chylothorax. So, how we can confirm that yes, I am dealing with chylothorax. So, appearance as in our index case, it was a milky white fluid, and there is a raised protein, maybe low or normal sugar, triglycerides are high. Along with that, ratio of the pleural fluid to serum cholesterol is less. Chylomicron in the pleural fluid by lipoprotein electrophoresis can be done, but because of difficulty in getting it, it is no more being done routinely. Cholesterol is normal or low, but if a milky appearance of the long-standing fluid and high cholesterol, but normal triglycerides, it is pseudo-chylothorax rather than the true chylothorax. So, what investigations we can do to confirm the underlying disease? These are lymphangiography, lymphscintigraphy, CT scan, and MRI. So, let us see what is the role of lymphangiography. So, lymphangiography is visualization of lymphatics by injection of contrast in the pedal area or in the lymph node. And this is, we take a plain X-ray and easy to perform, but it is associated with a poor resolution of images and radiation exposure. And since better imaging are available in form of a CT, lymphangiography, and MRI, this is no more being done. So it is something like if you inject contrast, then you can see the lymphatics, and then some of the leak can also be visualized. But as you will see in the next slides, that it is not of a good quality image. So lymphangiography, you have seen. Lymph scintigraphy is a minimally invasive imaging with insignificant exposure to ionizing radiation and without known adverse effect. Radio tracer technetium-99 sulfur colloid is injected intradermally into the interdigital web space. And then images of the whole body is taken by a dual head camera, gamma camera. But it has a low spatial resolution and lack of uh, anatomic landmarks. And that's why it is only used in diagnosis and management of lymphedema. So you can see here that this thing, the radio tracer is uh, uh, increased in certain parts of the body where there is a abnormal lymphatic proliferation. Then computerized tomography, lymphangiography. The CT scan after injection of the contrast, which may be iodized, water-soluble contrast, or ethiorized, and images provide a good anatomy, faster image acquisition, and can be performed in patients with a metal implant, and also allows for patients who cannot tolerate a full MR imaging. So, a CT-guided intervention such as a thoracic duct disruption can be performed immediately. So, this is an intervention can also be performed if you are doing a CT lymphangiography. And this is included. You can see here in this image that the contrast was injected in the bilateral inguinal nodes and it is going up in the abdomen, and here you can see the leakage also. So it provides both these advantages of the anatomy as well as leakage. Then dynamic contrast enhanced MR lymphangiography. It is minimally invasive without radiation exposure. Ultrasound guided contrast is injected in the inguinal node and quicker than conventional fluoroscopic lymphangiography and lymph scintigraphy, and can be performed in children who have a right to left shunt also. Assessment of retroperitoneal lymphatics, cisterna chyli, as well as thoracic duct anatomy or abnormalities such as blockages, leaks, and abnormal lymphatics perfusion can be identified easily and more precisely with the dynamic contrast enhanced MR lymphangiography. The technique has been successfully used for understanding of the lymphatic anatomy and planning or percutaneous embolization in patients with a plastic bronchitis, traumatic chylothorax, as well as neonatal lymphatic disorder. You can see here that this is specifying the thoracic duct and lymphatics, and you can see here that this is leakage also, and where all it is being leaked. So now question comes, what test do you use in a clinical practice? So the investigation of choice is dynamic contrast enhanced lymphangiography. And as there is no radiation exposure and gives good result to identify abnormality, but problem is it needs longer sedation or anesthesia and cannot be performed if there is a metal implant. And CT and lymphangiography, as you had seen, may be investigation of choice if sedation or anesthesia risk is high or having metallic implant or facility for MR is not available. Lymph scintigraphy and lymphangiography both are not being used now. The other investigations would be imaging of the other part to look for the lymphatic abnormality, whole body lymph scintigraphy or PET scan, and blood investigation like biomarkers for cancers, inflammatory markers, or tissue biopsy can be done. So this is all from my side. Over to Dr. Mendeli.
Yeah. I think now I would like to invite Dr. Amal to explain the investigation from the radiology department. So the slide is yours, Dr. Amal, please.
Okay. Thank you, Dr. Rina, and good evening, Professor and Dr. Please allow me to share the CT scan about the image of the patient. Yes. Okay, so the patient went to our hospital and to our department on 9th May because of the lump in his back. So we did the CT scan contrast, and our findings at that time was there's a lot of fluid collection, especially in the hemithorax, in the pleura region of the hemithorax. And this is I'll show you. Okay, this is the chest tube. The patient have two chest tube in the left hemithorax and in the right hemithorax. So as we can see here, I will show you in the coronal projection. Here we can see. So many fluid collection, especially in the basal and also in the mediastinum. And here we can also see the loculated of the fluid collection, especially and predominantly in the left of hemithorax. But on the right of hemithorax, there's only a little of fluid collection here in the posterior. So, and also we can see clearly in the sagittal projection the lumps that the patient symptoms here. So this is the fluid collection also in the subcutaneous region, in the posterior of the vertebra, in the subcutaneous region. So this is the symptoms of the patient. So from this image of the CT scan, we can conclude the fluid collection, especially in the left of hemithorax, and also we can see the loculated fluid collection. But not only fluid collection in here, we can see also the erosion, bone erosion in here. I will show you in the coronal more clearly. Yeah, in here, just so we can see the erosion of the costae, especially the costae that have involvement with the fluid collection. So based on the analysis of the fluid collection, the collection is a chylothorax, and we can see the costae erosion that have adjacent with the chylothorax in here. So at that time, probably we are thinking maybe this is the Gorham's throat disease. So after several days, the patient, we did the CT lymphangiography, and then I will show you the CT of lymphangiography. Yep. Here then, on 15 May, we did the CT lymphangiography. And then, as we can see here, this is the contrast. So I injected the contrast from the lymph nodes. So this is the lymph vessel in the thorax region. In here, we can also the leakage in the subcarina. So we can also see the contrast into the lymph vessel in the region of the bronchi in the airway. This is the contrast still go to the cranial. Here I will show you into the cranial, and then we can also see the leakage here near the subclavian vein. So this is the region where the lymphovenous valve in the left subclavian. So we can also see the leakage here. So that's the cause of the fluid collection that we can see in the CT on 9th May. So this fluid collection is, there's also still fluid collection on the 15th May. In here, we can see clearly the leakage in here. So there's still fluid collection in here also. And in the region of the subcarina also, we can see the leakage here. So actually, during our CT scan, the fluid collection is heavily on the left hemithorax. And until now, we cannot see any sign of mass or tumor in the region of the thorax. So we conclude our findings of the CT before and CT lymphangiography, the leakage of the lymphatic vessel in the region of the subclavian, left subclavian vein, and also in the subcarina. And I think that's all for the findings of the CT. Thank you, Dr. Rina.
Okay, thank you very much, Dr. Amal. I think it's a very comprehensive and clear explanations about the finding from the CT and also the lymphangography. And I would like to invite Dr. Madeline again. What is your analysis now, or what is your next management or the diagnosis that you made to this patient when you manage this patient?
Thank you, Dr. Rina. Moving on. Physis, can I get the control? Thank you. Okay, sure. Let me move forward to the analysis of the etiology of chylothorax. So we try to summarize all the causes of chylothorax that are possible: traumatic, malignancy, infection, congenital, and syndrome. From traumatic, no history of surgery, but however, he had history of trauma. But we are not sure, we were doubtful that the history of trauma was significant enough to cause this extensive of disease. And he had no fracture. From malignancy, those are also not subjective. The lymphoma, Kaposi sarcoma, the clinical symptoms was not suitable, as well as the additional examination. For infection, TB was not diagnosed due to expert and tuberculin were negative. Histoplasmosis and filariasis were also not suitable in the patient. From congenital, lymphangiomatosis and lymphangiectasia usually occur early in life, so it is not suitable in this patient and also not seen in current CT scan. However, congenital generalized lymphatic anomaly was possible because it can occur late onset, and the leak in our patient was in multiple sites. For syndrome, we suspected that probably Gorham-Stout syndrome was the culprit behind all of this. However, he had no fracture, but the radiology showed deformity with bone erosion and lytic lesion. As for other mutation, as for neuropathies or genetic mutation in RAS and PK pathways, the patient had no distinctive facial feature, no congenital heart defect, and no developmental delay. Thus, the most possible etiology for this patient are congenital generalized lymphatic anomaly and Gorham-Stout syndrome.
Okay, thank you, Dr. Madeline. So for this case, we still have the possible working diagnosis. And with this condition, so we are asking you, how will you manage the persistent chylothorax in this patient, whether you will increase the dose of octreotide, or you consider intranodal lymphangiography with lipiodol, or thoracic duct ligation, or doing a pleurodesis. Please give your opinion in the polling. Anyone still want to give a suggestion? But from the now polling, we see here that half of the participants is choosing for doing the ligation of the thoracic duct. And now we are going to hear from Professor Goh about the management of chylothorax in children. So I hand over it to you, Professor Goh.
Thank you, Rina. So I'm going to talk about management of chylothorax, and basically management can be divided into both a medical management as well as surgical management. And as you've heard, medical management will include placement of the chest tube to drain the chylothorax and dietary manipulation, particularly with a low-fat diet with MCT or medium-chain triglyceride supplementation and a high protein diet. And we can use drugs. The one you've heard is octreotide, which is a somatostatin analog. And there are other drugs that have been tried as well, such as epinephrine, which is a symptomatic, which has been tried in adults for post-cardiac surgery, chylothorax, and I will talk a little bit about sirolimus as well. Surgical management would, of course, include thoracic duct ligation, as many of you have suggested, pleurodecies, as well as pleuroperitoneal shunts. And I'm going to talk about some other interventions that have been tried as well for chylothorax. So if you look at the management goals, the main management goals is really to relieve respiratory symptoms, because these patients do tend to get respiratory compromise because of the collection of chylothorax in the pleural space. And you want to prevent recurrence of these chylothorax, as well as prevent or treat malnutrition and immunodeficiency, because with the loss of chyle, of massive amounts of chyle in the chylothorax that you are draining, you are losing protein as well as fat, and immune cells as well, because this is what is found in chyle, right? So you do need to manage the nutritional aspects quite closely for these children with massive chylothorax. So besides placement of the chest tube, one of the suggested flows will obviously be to do as what our Indonesian colleagues have done, is to look at the chyle volume. And if the volume is high in this particular flow, they have suggested that you can consider surgery straight off, right? And they suggested thoracic duct ligation as the first surgical procedure. And if that fails, then to go on to consider pleurodecies or a pleuroperitoneal shunt. If the chyle production is not high, then you can consider medical management first. And that would include, obviously, dietary management together with the use of drugs. And the dietary management will include the use of enteral diet containing medium chain triglycerides, and the use of drugs, but most often will be octreotide. And if the chyle production continues to be high, then you will consider total parenteral nutrition with IV lipid emulsions. Okay, and if the chylothorax persists after 2 to 4 weeks of medical management that's considered failing medical management, then you go on to surgery. However, in a newer article, despite whether you have a high volume production or a low volume production, you can consider both dietary modification as well as drugs for both modalities, whether it's high or low volume production. But of course, if there's high volume production, you may want to consider operative interventions a little earlier. And operative interventions can include, besides thoracic duct ligations, things like thoracic duct embolization, pleurodecies, and I will talk about other interventions as well. So definitely, if dietary modification fails, or if the initial surgical intervention fails, then a multidisciplinary approach for imaging and operative intervention will be instituted or suggested. So if we look at the drugs that is used in medical management, as I said, the most commonly used are somatostatin analogs, which commonly, the most common being octreotide. It acts by binding to somatostatin receptors, and this reduces chyle production and lymph flow by reducing splenic blood flow and intestinal absorption of lipids. It is given as a continuous infusion, starting from 1 to 2 microgram per kilo per hour, up titrating to about 10 mics per kilo per hour generally with response seen in about 5 to 7 days. However, in cases with large volume chylothorax, there have been several case reports which have suggested that a higher dose of ultradipe may work better. And they've actually gone as high as 20 mics per kilo per hour. And these have been shown to be effective, particularly when the conventional dose of 10 mics per kilo per hour does not work. A systematic review on the use of ultradipe for chylothorax was inconclusive, mainly because there was so much variability in dosing. Okay, and also you realize that chylothorax, there are many conditions that can cause a chylothorax, and therefore you will find that it is difficult to really review how effective ultradipe is. However, the systematic review did suggest that ultradipe may be more effective in congenital causes of chylothorax, particularly when given to infants with large volume chylothorax and treated with higher doses and for longer periods. The specific drugs that can be used for special conditions I'm going to talk about will include sirolimus and trametinib. And that's because molecular studies have identified that somatic mutations involving the RAS-MAPK and the PI3K-AKT mTOR pathways have been found as underlying the pathogenesis of several of these complex lymphatic anomalies. All right, and as a result of that, many of these drugs, such as sirolimus, which is an mTOR inhibitor, has been tried and used to treat congenital lymphatic anomalies, and these work by inhibiting the excessive growth of lymphatic vessels, which are seen in many of these complex lymphatic malformations. The trametinib is a MEK inhibitor and has been used again for complex lymphatic anomalies with mutations along the RAS-MAPK cascade, particularly in ARAF and Noonan syndrome, which carry the SOS1 mutation. It's also been used for caposiform lymphangiomatosis, which carries also the NRAS mutation. So some of these drugs definitely can be tried, particularly if you're thinking along the lines of complex lymphatic anomalies. So besides medical treatment, there's surgical treatments that can be offered to children post-thoracic duct ligation, as many of you have suggested, and clipping is one method, and this shows a successful ligation with clips, which showed no leak of lymph into the thorax after the thoracic ligation, thoracic duct ligation. The other treatment modality is the use of intranodal lymphangiography with lipidiol. And you've heard Professor Cabra talk about intranodal lymphangiography, right? It's a form of MRI lymphangiography as a diagnostic tool. However, it can also be used for intervention. All right, and what they found in this Korean series, when you inject intranodal lymphangiograms with lipidiol, not only will it demonstrate where the areas of Karl leak is, but it also acts as a form of thoracic duct embolization. And in this particular series, in Korea, they found a success rate of 90% with a median time to chest drain removal about 3 days after the procedure was done. So it is a procedure that can be considered if you are thinking in terms of thoracic duct embolization. So not only is it diagnostic, it could be therapeutic. Sclerotherapy can be also done, but this is usually done for simple lymphatic malformations that involve like either a single large or small cyst, macro or mixed cyst. Okay, and sclerotherapy involves injecting a sclerosing agent such as bleomycin or ethanol into the inflow tract of the lymph of these cysts. And a percutaneous approach can be done using either ultrasound guidance or CT guidance to inject the sclerosing agent. Success rates have ranged from about 84 to 87% with good outcomes. So I'm going to talk very briefly about the complex lymphatic anomalies that have been identified. And these will include the generalized lymphatic anomaly or GLA, caposiform lymphangiomatosis or KLA for short, the central conducting lymphatic anomaly or CCLA, and Gorham-Stout disease, okay, which is GSD for short. So there are definite overlapping features of these complex lymphatic anomalies, particularly as they all present with some form of chylothorax and usually have multi-system involvement. However, there are also some distinguishing features. And this is just a diagram showing the mutations as well as the signaling pathways that are involved in these lymphatic malformations that obviously demonstrate where the RAS, MAPK signaling genes and pathways occur, and where these drugs such as sirolimus may be useful in treating these lymphatic disorders. So if we look at the clinical features in these complex lymphatic anomalies, for generalized lymphatic anomaly or GLA, they usually involve macrocystic and or microcystic lymphatic malformations that affect multiple sites. They can cause pleural effusions, unsurprisingly, because they can get a chylothorax. They will also get splenic involvement and bony lesions, which are typically involving the medullary cavity of the bone. With caposiform lymphangiomatosis or KLA, you can get a mediastinal mass besides the pleural or pericardial effusions, possibly in hemorrhagic as well as splenic lesions. Again, they can get bony lesions, especially of the axial skeleton, but the main distinguishing feature is that they have consumptive coagulopathy and hemorrhage. Okay, and so typically these patients will also have thrombocytopenia. With Gorham-Stout disease, there is a progressive osseous lesion or bony lesion, but these bony lesions usually involve cortical destruction, which is very different from GLA, where it starts in the medullary cavity, and therefore the whole bone disappears with time. It's called the vanishing bone syndrome, right? And you get infiltrative soft tissue masses as well as pathological fractures. And with CCLA, which was previously known as pulmonary lymphangiectasia, you get dilated central lymphatics with leakage, pleural or pericardial effusions, ascites, and generalized edema. It can get splenic lesions or abnormal MR lymphangiogram with disruption of central lymphatic channels. But in this particular condition, there's no bony lesions. Okay, I'm not going to talk about PROS. So if we look very briefly at GLA, it's a multifocal lymphatic malformation, which are usually intrathoracic as well as intra-abdominal, and you get bone and visceral lesions. And as I said, the bone lesions tend to involve the medullary cavity and spares the cortex, and usually involves the appendicular skeleton. They may have somatic mutations in the PIK3CA with disrupted lymphatic development as well as growth. And a functional MR lymphangiogram will demonstrate multiple sites of lymph leakage, and targeted lymphatic embolization can be done to treat this condition. With Gorham-Stout disease, it's a rare disease characterized by progressive osteolysis angiomatosis. So the bone is gradually being eroded away and it disappears over time. And therefore, they present with multiple fractures. Recent molecular findings suggest that somatic activating mutations in the KRAS and dysfunction of the RAS and APK signaling pathway can drive the pathogenesis. You may want to consider a bone biopsy, and if we do that, it will show infiltration with proliferative thin-walled blood vessels with inflammatory infiltration and lymphatic vessels. So the management will also include management of these bony lesions, because they have found that if you treat them with bisphosphonates as well as calcium and vitamin D, you can halt the progression of these osteolytic lesions. Okay, so you may or may not need to give radiotherapy, and usually in children, radiotherapy is not given. And sirolimus has been given with very good results. So if you look at the management flow of patients with chylothorax and bony lesions, besides treating or managing the pleural effusion or the chylothorax, treatment obviously will include nutrition as well as drug therapy. And if you're thinking of particularly complex lymphatic malformations, then sirolimus may be considered besides octreotide. And the management of the bony lesions will include the treatment with bisphosphonates, vitamin D, and calcium. If medical treatment fails, of course, surgical interventions can be considered. Thank you.
Okay, go ahead, Madeleine. What is your management on this patient?
Thank you, doctor. So this is the summary of a management for the patient in our hospital. We initiate TPN at first, switch to low-fat diet after the volumes decrease. But over the course of the low-fat diet, the volume went up again, more than 20 ml per kg per day. Thus, we started the TPN again. Because the TPN only was not sustainable, we combined the low-fat diet with parenteral nutrition and initiate octreotide from 2 micro per kg per hour, up titrate up to 10 micro per kg per hour, because no significant response was observed. It was down titrate and stop. At first, we tried to do the subclavial embolization. However, no fit size for the patient, so it was not done. Then we proceed to ligation of thoracic duct, transabdominal approach per laparoscopy. It managed to cut the cal production down to 400 ml. And the patient was discharged with a right brain at that point of time to continue ambulatory care. At observation, we see that the volume went up and down again. However, from the initial after the surgery, it was zero hemorrhagic. We can see that the production is now chyled again, and we are still trying to find the next best approach to our patient. With the etiology, we suspect of the CGL as well as the Gorham-Stout.
Okay, thank you. I think that's the end of the story of this patient, but actually it is unfinished story because we still not sure about the diagnosis. So if Professor Shen is here, hello, Professor Shen.
Yes, I'm here.
Yes.
I'm sorry, disconnected at that time. But anyway, you and also the following professors, they have mentioned the reasons and also how to do the diagnostic.
Yeah. So with the informations, the findings that we already have on this patient, so can you give us like a summary? What is the possible diagnosis for this patient, Professor Shen?
Okay, I think that patient, they have some the problems of the back and also some leakage to the bone. I think there's a kind of a multi lesion. So probably it's a kind of a malformation of the lymph node, lymph vessel. Yeah.
Okay. And Prof. Cabra or Prof. Goh, do you have any more detail about the possible causes or maybe the suggestion for colleagues in Jakarta to perform another modalities to confirm the diagnosis and then we can give more proper management?
Thank you, Dr. Reena. In the index case, we could not establish the diagnosis. Still, there is a multiple leakage and large volume which is still leaking. So there are two things. That one is how can we reduce this uh, leak by some intervention. Though surgery has already been done, but still there is a significant amount which is more than 5 milliliter per kilo. So one of the possibilities is that we do a CT lymphangiography using a lipiodol that will block all the leakage to some extent. And since there is a multiple sites leaks, so there is definitely lymphatic proliferation. In that case, you block it with the lipiodol CT angiography and add sirolimus, say 3 milligram as a loading and then 1 milligram per meter square daily with monitoring every fortnightly or every month. So that may be a useful intervention for this child.
Okay, thank you, Prof. Cabra. Professor Goh, do you have any additional things to share?
Yeah, I mean, basically, I agree. It looks like there's definitely ongoing production, and I think looking at a possible diagnosis, it looks like it's going towards that of a possible complex lymphatic anomaly. So given that you have not tried sirolimus, you can possibly try sirolimus, and I would say that, as I mentioned, in terms of intervention, you can try the CT lymphangiograph with the lipidiol because that is a form of thoracic duct embolization and maybe a bit definitely they both shown quite good success rates, yeah, for congenital these forms of complex lymphatic anomalies. So I agree with Professor Cabra, yeah, that these are two modalities that you can possibly try in your patient. Yeah.
Yeah. Thank you. And we have many questions here, and I think we still have maybe 5 minutes to respond some of the questions that has been answered in the chat. So one of the question is about the best modality of choice in 3 months old infant with Chylothorax. Can someone respond to this question?
Professor Reena, I have already answered that if
Oh, yeah,
there
yeah.
is a problem of sedation, GA, or there is a metallic implant, you can go ahead and do a CT scan. Now, CT scan will require only few seconds. But it is better to get a MR lymphangiography with a sedation, good sedation or GA.
Okay, yes. And the next question is, in cases of refractory chylothorax where no lymphatic leak is detected on CT lymphangiography, that the best modality that we have, for example, are there any factors that may influence these outcomes? Maybe Dr. Amal, or can you respond for this question? When we have the chylothorax, but there is no lymphatic leak detected on the CT lymphangiography, so what is the possible factors that cause we cannot detect the leak of the lymphatic duct?
Okay. Thank you, Dr. Rina. Maybe I will try to answer the question, and thank you for the questions. Yeah, actually, first we need to know about the morphology or the content of the fluid collection first. If it's a chylothorax, then probably we are facing in two scenario. First, because of we use CT lymphangiography, it is not a dynamic uh, uh, sequence of the CT. So probably we will have a chance to miss during the leakage of the lymph vessel first. And then if we use the dynamic scans as MRI lymphangiography, we can clearly, easily to see through the time, especially in, for example, like every 2 seconds or even 1 second, we can see clearly if there's any leakage. So we need to make sure if it's we use CT lymphangiography, the scan time and capture of the CT, it's appropriate. If it's appropriate, then we do not see any leakage. Then might be we need to think about is there any other causes such as like I mean the other leakage that really small, but it is very difficult for CT to get the leakage for the small leakage in the lymph vessel. So we need to have like other modality like lymphoscintigraphy, because lymphoscintigraphy is very sensitive. If it's there is a very small of the leakage, but the lymphoscintigraphy disadvantage is it's really difficult to see clearly about the anatomical of the leakage, not like a CT or MRI. So I think the best modality to acquire for that cases, maybe we ask for dynamic scans of MR lymphangiography first to check whether there is really any leakage, if it's small or not. I think that's
Okay,
my
thank you.
perspective of radiology. Thank you so much.
That's very helpful and very comprehensive answer. It improve our knowledge about how is the technique for the radiography. And I think because of the limitation of the time, we should stop our discussion about this case. We already listened to our experts about how is the approach of the diagnosis, the investigations, even for the radiology findings, and also the comprehensive management for approach children with chylothorax. So I hope that this session will improve our knowledge and experiences and also skills to manage children with chylothorax, which usually it's not easy to manage. And I think that's all from us. Thank you very much. And I will hand over this to Professor Ananathan, who will close this session. Thank you all.
Thanks, Rina. Thanks to Dr. Madeline, Rina, my good friend, and of course the esteemed panelists who gave us a wonderful overview of this very difficult case. I'm sure each one of us have our own unique case like this that gives us sleepless nights. But my role today is also not only to close the session, but remind you that we have another session, our 12th APPS Grand Round, which will be happening on the 26th of September. Here we have a very interesting case of an unusual obese child with hypoventilation, and another team of experts, Professor Zifei from China, Beijing's Children's Hospital, with the moderator, Professor Kun Ling. So please make sure that you all look out for our poster and do join us again and see what we can learn from these experts and this interesting case.